Could everyone put their mics on mute? There's some feedback coming in from somewhere. Thank you. Welcome, everyone. Happy Friday to the Mental Health Parity Advisory Committee meeting. I know it's been a long time, so I'm excited to hear everybody since we haven't met in a while. I'll start with roll call and then we'll do introductions. Carly Fleege. Dr. Don Fowles, we know is Carly, was that you? Carrie Steven.
I'm here.
Kathy Busby. Monica Curry.
I'm here.
Monica, is that you? Dr. Roger Wilson.
Here.
Mr. Thompson. See you, Vista. Can't hear you. Nicole Porter. And our newest committee member, Vanicia Hill.
I'm here.
Welcome, and I will introduce you shortly. We have our new director present. I want to introduce her, Director Barbara Richardson. She is new to the department. She comes with a great deal of experience. She served in Nevada as well as New Hampshire. And we are excited to have her and all the experience that she's bringing to Arizona with her. Director Richardson, the floor is yours if you want to make any comment or say hi to the people.
Just hello, everybody, and I'm just excited to be here. It's great that you guys have this great panel, and look forward to working with everybody.
Thank you. And then our newest committee member, as we are down a few members, is Vanicia Hill, and she is representing as a family member. She has a plethora of experience in the mental health field, from the SMI world with the REBA to residential treatment to children. So I don't know if you want to say anything additional, Vanicia, but welcome. Thank you for joining us.
Just thank you for having me. I'm excited.
Okay. You can go to the next, to like the third slide, Eliam. If you can hear me. The next part of our agenda is our media update. We are going to be doing a suicide awareness campaign in September. And we just ask everyone to, if you haven't liked us on Twitter or LinkedIn, that you do so. The Department of Finance, Insurance and Financial Institutions, we have a Twitter page. We also have a LinkedIn page. So as we tweet stuff out about suicide awareness, you can retweet us, you can repost us on LinkedIn. We want to definitely get the message out, as we know that it is an important message that we try to come together, stop the stigma, and prevent suicide. So if you could keep an eye out on that and help us promote suicide awareness, that would be fantastic.
Lynette, I don't see the slides progressing.
I didn't know if Elian could hear me.
I can hear you, so move on to the next one.
To the third slide, I think, Elian. The beginning of the agenda.
Oh, sorry.
That's okay. Yeah, my slides aren't advancing, so.
Oh, let me stop sharing and then start all over.
Okay.
She is getting that ready. We're actually to the program updates, and if you have the slides from Josh.
Okay, so let me backtrack for a little bit here.
Okay. Josh is from Access, and he works with the Suicide Mortality Review, as well as the crisis system, and he has some updates for us. Josh, the floor is yours if you're ready.
All right. Well, thank you very much. Again, my name is Joshua Segemeyer, and I'm the Suicide Prevention Program Manager with Department of Health Services. So I'm here today to talk a little bit about the new state plan that's being developed, and then drop a couple of quick updates around 988 and some of the functionality changes that we've seen over the last year. Slide, please. Okay. See, is the slide advancing? I can't see on my screen.
I did move it to mine. I don't know why WebEx is acting up. Let me start all over again. Okay, so I'm gonna share. Can you guys see that?
Yes.
It
Yes.
seems like if I put it to the slideshow function, that it's freezing up on everybody. So is it okay for me to just turn the page or turn the slides from this version?
Yeah, that's okay
Yes.
with me.
Okay.
Thanks.
All right. So talking about the next state plan, that is going to start this year. So it's 2023 through 2025. And this next plan has three main influences. Now, I'm not going to spend much time describing them, but I think it's important to understand that our plan is nested inside the best national guidance. So we'll talk briefly about all three of them. This slide shows some of the major themes from the first resource, which is the CDC Roadmap for Suicide, or Suicide Prevention Resource for Action. They just changed the name of it, but that's their most current guide. And kind of the highlight that I think that is the most important part of this whole guide is the four-stage model that looks at suicide, not just from an individual perspective, but also relational, communal, and societal angles. So you can kind of see their four-stage model there on the slide. And the other big thing that the CDC brings into this newest version of their resource is the adverse childhood experience connection to suicide and suicidality. And then finally, they offer some advice as to what a model program should look like. Moving on to the next slide. All right. And so this slide shows what happens when you merge that CDC plan with the Surgeon General's call to action suicide guidance document. So we start with our four-stage ecological model, and that allows us to apply suicide prevention concepts at any level in society, from the individual to local to statewide. We add in the continuum of care that tells us where to direct our efforts, and that's before intervening during a crisis or after a suicide event, there, prevention, intervention, postvention. And the last step, once we know what kind of initiative and where in society we want to apply it, the social determinants of health show us which levers to pull to achieve the intended outcome. So this gives us our strategic framework for our state plan. Slide, please. Okay. So the final part of it, I mentioned the CDC resource and the Surgeon General's guidance. The Suicide Prevention Resource Center conducts a state needs assessment yearly. And so this piece of the plan comes from that annual state needs assessment. We'll break it out here in a little bit in a few more slides, but you can see with the green, yellow, and red colors which of the 6 identified infrastructure areas Arizona is strong in and where we need to improve. Slide, please. Okay, with that background and context, let's briefly review the major points of the new plan. There are 3 parts to this plan, making it much larger than the 2022 to the 2023 state plan. The first bullet there is the comprehensive plan. And so that can best be described as those things that ADHS can best do. And we'll get to that here on the next slide, so we'll talk a little bit more about that. The second piece of the plan, the infrastructure plan, we're going to address those state needs, those infrastructure needs, through a combination of an RFGA offering and an IGA to provide a suicide prevention specialist in a specific county. And we're also engaging in an ISA with a public university to evaluate the suicide prevention program and its implementation of this state plan. So I'll provide some of those details on those projects in a couple of slides. The final bullet there is the partnership plan. And the partnership plan is the culmination of about 14 months of work. And when you count all the 6 work groups are involved with that, almost 300 people and over 100 organizations participated in developing this part of the plan. And these are suicide prevention recommendations across 6 disproportionately affected population groups. These recommendations are currently in the final stages of being vetted for inclusion into the plan, but the end result will be somewhere between 25 and 30 stakeholder-created and developed suicide prevention recommendations. These recommendations will be actioned by the same work groups that developed them with the administrative and logistical support provided by our suicide prevention program. So that's the 40,000-foot overview on all 3 parts of the plan. Slide, please. So I wanted to go into a little bit more detail on the comprehensive and the infrastructure plans today. And so just briefly, you can see that the comprehensive plan is broken out into 5 major strategies. That first strategy, data collection and dissemination, has 4 tactics that we'll be pursuing. The first is to ensure the functionality of our suicide death data and suicide encounter data dashboards. We're going to continue publishing our external reports and providing as needed technical assistance to our data consumers. Our 4th tactic is to continue the suicide mortality reviews, all of which the counties that are participating are in their 1st year or 2nd year. So that's going along pretty well. Our second strategy there, support to crisis systems, has 2 tactics. And that is to continue what ADHS's role has been up to this point, which is supporting the advertising for 988 and coordinating the cross-agency communication and facilitation of those discussions. So those would be our 2 tactics to support the crisis systems. Our 3rd tactic is going to be a continuation from our current state plan around occupation-specific suicide prevention. So we're going to be starting up a work group composed of industry members and stakeholders from the most at-risk populations. That's our first tactic. And our second tactic is then to utilize the work of that work group and push it out to employers through the ADHS Healthy Arizona Worksites program. Our 4th tactic there is to continue our support to disproportionately affected populations. So we're going to continue the work groups. We're going to continue to provide technical support and assistance to the people in those work groups. And then we're going to be looking at either starting up or joining work groups that focus on disordered eating and on the connection between substance use, misuse, and suicide, in acknowledgement that the state opioid response works in the cubicle next to me, and that's a pretty easy linkage. So the strategy number 5 around relationship building has 2 tactics. The first tactic is to formalize our relationships with other state agencies. I particularly work a lot with Access and Department of Education, just to name 2. I also work with Department of Veterans Services. And so with these relationships, we'd like to get them formalized so that we know who's responsible for what and that we have an official understanding. And our second tactic there is going to be to do the same with our stakeholder groups that we work with a lot. Okay. So those 5 components round out those things that we'll be doing at ADHS. and that's our part of the plan, is the comprehensive plan. So slide, please. These next three slides kind of show off a little bit of the infrastructure plan. This first slide shows our state results for a couple of different elements, but I want to draw your attention to LEAD. LEAD is one of the ones that we need to upgrade. And so that talks about the formalization of responsibilities, the standardization of responsibilities, and just sort of cross-leveling across the government and across our stakeholders. So we've got that at 67%. Next slide, please. And you'll see this partner element here. When the program moved from Access to ADHS, it had been there for a while, and they had a lot of partnerships. And so the reason why it moved to ADHS, though, is because we own all the data around the vital statistics in that. So what you see there between partner and examine is a flip-flop. ADHS has the data, but not the partners, and Access had the partners, but not the data. And so moving forward in our new plan, we're looking to upgrade our partnership element with some of those ideas I mentioned in the comprehensive plan, but also some things I'm going to talk about on this next slide. Slide, please. So now that we've talked about these, or shown off these three slides, the final element is guide. And so those are the three sections of the state needs assessment we're going to be addressing through our infrastructure plan. And that infrastructure plan is going to come out in the form of an RFGA, hopefully hitting the public notice next week. But there are 3 tiers of awards, and the tiers are to conduct training, like a singular training event, to conduct a large training event like that would extend for a year. Think maybe running 12 sessions of QPR, 1 a month. And a final category for logistics and capacity building. Okay, so I'm going to briefly explain each one of those areas. The training awards, like I said, are to host an individual training session. And those can be around train the trainer events, so that you can get a trainer certified to certify other trainers in your organization, or hosting a gatekeeper training event, organizational training, professional development, if there's something like the psychological autopsy training you want to send personnel to, that would be covered in that section of the RFGA. The second section, the training events section, this is used to organize, like I said, those large multiple iteration training events. And in addition to funding the actual training, it can be used for facility rental, equipment rental, and speaker fees at those events. The final category, and this is the one we're most excited about, the logistical and support capacity building part. This is given to us directly by our prevention stakeholders. What do they need for their organizations after the pandemic and getting back on their feet, et cetera? So this money can be used for physical printing, expendable office supplies, computer program license renewal like Office or Acrobat, external marketing, web pages, advertising campaigns, data collection, data systems, focus groups. And one other thing that's in there is language and accessibility services. We had a stakeholder ask us to put some provisions in there so that she could apply to get things translated into American Sign Language and Braille for her organization. So that's in there as well. So the final 2 parts of the infrastructure plan are the IGA that will be signed with a county to put a suicide prevention professional inside there for 2 years with some seed money for projects. And then the ISA with a public university so that we can conduct an evaluation as to how well we put forward this plan and execute it. Slide, please. So now we've talked about 2 parts of the plan. We'll save the partnership plan for a future update. This is the plan for the plan, and it lays out some of the major milestones. We're almost done with the first draft phase, and I'm just waiting on a couple of those things to finish up those projects to finish up so I can put those results into the plan. And then it'll be the rough draft will be finished. It'll then go up through my chain of command for edits, and then we're going to put it on display internally for feedback and upgrades. Once that finishes up, we're going to go through the same process with external stakeholders. And hopefully the plan will go through a final round of revisions and be published in late September, early October. Okay, so that is the update on the state plan. Slide, please. I don't have any slides for the 988 update, but I do want to give you some information on that. We're about 13 months in since launch. We've answered over 60,000 calls, and Solari is continuing to set the national standard for 988. So everything's running smoothly with it. But with regards to functionality, I just wanted to talk a little bit about it because there are some options that you can use other than just dialing in 988 and waiting for the service. They're in the process of upgrading to provide services to specific populations. So the first upgrade was to integrate the Veterans Crisis Line, which can be reached when you dial 988 by dialing option 1 after hearing the pre-recorded message. 988 initially launched last year with Spanish language support, which is dialing option 2. The newest national upgrade was to add LGBTQ+ specific support, which is dialing option 3. And the latest, greatest, newest upgrade is available only in Washington State, where it's being piloted. But dialers from that state can use dialing option 4 to reach the Native Strong Line, where calls are answered by Native crisis counselors who are tribal members and descendants closely tied to the community. So the Washington pilot will hopefully result in this expansion of the Native Strong service nationwide. But for right now, there are still lots of ways for those in crisis to reach out and receive some more specific support. So that concludes my update. The suicide prevention website link is at the top of the business card there, and my contact information is available right there. So pending any questions or comments, that concludes my update.
Hey, Josh, just one question. Under the relationship building element, is there a collaboration with the tribal nation with the Suicide Prevention Act?
Yes, we have our collaboration is in our Indigenous Peoples Work Group, where we have I think there's like 37 or 38 members of that, and they come from all over. There's different tribes represented. There's tribal behavioral health services, urban Indian organizations, tribal serving stakeholders, our tribal liaisons part of that. So we do have that outreach, and they were one of the groups that provided prevention recommendations into the next plan.
Hey, thank you.
Josh, I have a quick question for you. This is Erin. I think it was about slide 6 or so. You had some bullet points and you were talking about occupation-specific prevention. You probably talked about that before, but that kind of stood out to me. And I wondered if you had any other information you could tell us about either the occupations that seem to be at high risk, I can guess, but won't. And maybe just a little more about how those were identified and what the work is to try to improve that.
So that's actually, I was able to pull up some statistics that I'm looking at right now. So the reason why we're doing this initiative is because the CDC shows that 45% of male suicides and 37% of female suicides occur in just 5 occupational categories. And so what those 5 occupational categories are vary between the genders. For men, it starts out at construction professions at 15% of all recorded suicides, and moves to transportation and logistics, production-based workers, managers, and salespeople. And for females, office administrators and support personnel, salespeople, healthcare practitioners, and food service workers. Oh yeah, and healthcare support personnel. That rounds out the top 5. So let me see here. I can send that over to you, Aaron, if you would like, but it's also available on the CDC's profession suicide prevention occupation part of their website.
Yeah, if it's on your website or readily available, that's fine. It was, like I said, it just kind of jumped out at me. I hadn't ever personally thought about the link between occupation and suicide, so I just found it interesting. Thank you.
Yes, this is Dr. Hennigan. Do you, or is Access going to be doing any events around suicide prevention in September that we could help support? Do you have a calendar of events that you could send out?
We're the partnership for that. We're going to be talking about that come the last part of this month between Access and ADE and ADHS. So I don't have a current list, but I do know that the governor's proclamation is awaiting to be signed. So we will have Suicide Prevention Month, in September. So hopefully we'll be able to get together cross agency and put that list together of what everybody's doing so that I can send that out.
Perfect. Thank you.
Hey, Josh, you mentioned provider suicide. Any collaboration with ARMA or the Arizona Medical Board?
Not yet. That's one of those things that we're going to be looking into. I've recently been talking about this issue with Chief Medical Officer, Dr. Villarreal, and she's been helpful at getting us into some of those more professional medical associations where I'm a mental health provider by trade, so I don't have those handshakes, but she's been real helpful with that.
Hey, thanks.
Anyone else have questions for Josh? I think I have one more. I know a few months ago, Jessica put a call out to have people join the mortality review committee or board. Do you still need members? Is that call still out? And if it is, and anyone is interested from this call, do they reach out to you to facilitate that?
Yeah, that would be outstanding, and thank you for bringing that up. I have a tendency to forget the suicide mortality review because it's not my program, but
Right.
it does fall under the program. So when Jessica left, she was recruiting for the state board, and that's what we're still recruiting for. Here
Okay.
in the next couple of weeks, I'm hoping to be onboarding the new suicide mortality review program manager, which is why it's such a great time to reach out if you're interested in being part of that.
Okay. We will keep sending that. I don't know. I will email you what she sent as far as the official call to see if that's still relevant. And if so, I can push that out again to the committee and other people to kind of help recruit members for you.
Appreciate it. Thank you.
Mm-hmm. Anything else for Josh? Okay, Josh, thank you so much. That was great information.
Thank you.
Elian, can you go back to the agenda? We are on item number 4.
Okay, let me open that up. No, not one. Okay. Share.
Perfect. So just a brief update. I can't go into a great deal of detail, but we have received reports. Our first round of triennial reports from the insurance companies, and they are under review. I can't speak to any trends or anything like that as of right now because it's a lot of information and we are combing through it. And so hopefully in the next coming months, we'll have something high level to report. But I don't know if there's any questions. I can't go into any further detail. No, if you have anything else to add, Aaron, but we do have reports that we are reviewing.
Yeah, all the insurance companies have submitted their triennial NQTL reports to the department, and they are under review. As we've said before, the information, the reports themselves are confidential, but once the department has completed its review, we will be able to produce some high-level aggregated information. And certainly, if there were any, enforcement activities or compliance activities associated with it, that that would become public information. But it'll be a little while before we can provide that level of detail to folks. So yeah, sorry if that's a little disappointing, but we did want to at least let you know things were in the works.
It's slow moving. For the next item under there, if you haven't heard, President Biden has proposed new federal rules to the MHPAC law, and you can find that it's on the website, the White House website. I can't even think of the website, but what if they go into effect? We suspect that we will probably have to amend our rules accordingly. So we will definitely need the committee's input at that time. But if you want to go in and look at that, there are more stringent outlined around prior authorization and things like that. So it's a dense document if you want to take a look at it, but be on the lookout for that, as we may have to do some adjustments to the Arizona rules in accordance to the federal guidelines. And again, Aaron, I don't know if you have anything else to add for that one.
Just that if I'm sure this audience is probably really familiar with the fact that those new rules have been proposed, but they are taking comments as well. So now is the time, if you have any input, to give it to the appropriate federal organizations.
Any questions, comments for that? Next, Aaron is going to do an overview of provider grievance and healthcare appeal rights.
Yeah.
So, Aaron, you have the floor.
All righty. And I don't know, are you guys still hearing that background noise when I'm off of mute? Do you still hear? I turned my air conditioning off. I was thinking maybe that was it. I don't know what's making that. Is it annoying when I talk? Or is it workable if I'm talking for the next 20 minutes?
I can hear you okay. You can hear that noise, but you're coming in loud and clear. So.
Okay. All right. Well, I apologize because there is no noise in my office here, so I'm not sure where that's coming from. But all right, Ellie, and I'm going to share, if you wouldn't mind ceasing to share. Oh, I guess you have to allow me to share. You have to give me the authority to share.
Let me change you to the presenter. Okay, you are now.
Okay. That doesn't look like I'm sharing yet, am I?
Yes, I can see.
Appeals and grievance?
Mm-hmm. Yep.
Okay, good. All right. It just didn't show up on the screen that I'm looking at. So, okay. Awesome. Thank you very much. Good afternoon, everyone. I'm Erin Klug. I'm the Assistant Director for the Product Filing Compliance Division at the department. And over the course of this year, the department had an opportunity to engage with a number of provider stakeholders on legislation. And through that exercise, we realized that there is a lack of awareness, I'll say, regarding two long-standing existing dispute mechanisms in the law in Arizona. And so we wanted to kind of take advantage of this audience, which consists obviously of providers as well as consumers and family members and health insurers. So, and give you an update or a reminder, a refresher on the two dispute resolution mechanisms that exist today for both providers and consumers. And those are our healthcare appeal laws and provider timely pay and grievance laws. And so I've got at least 20 minutes of remarks here, so I'll try to speed through this pretty quickly. Mostly this is just to refresh everybody's memory. The health plans are going to be extremely familiar with both of these, so this is predominantly intended to be a refresher for providers and consumers. Healthcare appeals are if an insurance, and I'm going to talk at the end about the scope of our laws and what they apply to, because our jurisdiction doesn't extend to federal government health plan programs or self-funded plans and that kind of stuff, but I'll get to that at the end. So the healthcare appeals law in Arizona is a mechanism by which providers and consumers can appeal a denied health insurance claim or a denied access to care mechanism. So prior authorization, a referral, a prescription, and that kind of thing. And I'll get into a little more detail. And a provider grievance is a complaint that a provider might have about generally a claim payment issue that is not a denial. And so I'll talk when I get into detail about that one, about what a grievance is and what a grievance is not. So let's start with appeals. The last slide I'm going to show you all, by the way, is a list of resources with links to the pages on the department's website where you can dig deeper into all of these topics, because this really is kind of a just whet your appetite kind of presentation. So when can you submit an appeal, a healthcare appeal? If you are if you have received a denial of a claim, denial of a payment for a claim from a health insurer, or if you have received denial of a prior authorization request, denial of a referral to a specialist, denial of coverage for a prescription drug, any of those sorts of things are eligible for appeal. And you have 2 years to appeal in Arizona if it's a denied payment. And obviously, if it's a denied access to care situation, you're not going to want to wait 2 years. So, and we do have both a standard appeal and an expedited appeal right. So if the service that you're trying to obtain for your patient, or that you, the patient, are trying to obtain is denied, and the inability to receive that service or treatment has the potential to cause detrimental harm to the patient, then you can request an expedited appeal. And there are very tight time frames associated with what has to happen for those appeals. So I'll get into that a little bit more in a minute. So who can submit an appeal? Healthcare providers can submit an appeal on behalf of their patient. Arizona law says that the member can appeal denials, and the definition of a member includes their treating provider. So, and the last time I looked at the statistics, it's been a little while, but it was about 80% of the appeals that we got were from providers on behalf of their patients. So we're not sure that everybody's aware of that, but we wanted to make sure that the behavioral health community was aware that you can appeal denials on behalf of your patients. And now let's talk about, how do you submit an appeal? Appeals have to be initiated at the insurance company. So you receive the denial from the insurance company, you go back to the insurance company to appeal the denial, whether it's a denied payment or a denied service. And the insurance companies all have established processes for receiving those appeals and processing them. They all recognize, or should recognize, whether the appeal is a standard appeal or an expedited appeal. If the provider believes that the lack of service would result in harm to the patient, You make note of that in your appeal, and you can specifically request an expedited appeal, which, as I said, will really change the timeframes that both the insurance company has to abide by, as well as the department. Because there's two levels of appeal. The first appeal goes to the both appeals go to the insurance company, but the first review of an appeal at the insurance company is by the insurance company. If the insurer upholds that the denial of the service or claim, then you can go back for a second time and request external review. And then the insurance companies are obligated by law to transmit that appeal to the Department of Insurance. We are the external reviewer. And they send all of the information over to the department electronically, and we get it all in one nice package. As I said, if it's an external expedited review, then the timeframes for the department to review that appeal are greatly shortened, as are the timeframes that the insurer has to do that expedited review. There are two types of denials for a claim. One might be that if the insurer says the claim is denied because there's no coverage under the insurance policy for it, and the other denial might be because in the insurer's estimation it was not medically necessary. So when that appeal comes to the department for external review, we look to see which of those two kinds of denials are applicable. If it is a denial for coverage, meaning the insurer says this insurance policy does not cover this service, the department has expertise in-house that can review and evaluate the coverages under the insurance contract. If there's any question about medical necessity, the department sends those appeals out to an independent review organization. We contract with several of them and vet them carefully. And they have medical behavioral health expertise, pharmaceutical expertise, to be able to evaluate the medical necessity of the services that were denied. And the decision of the IRO comes back to the department, and if they have indicated it is medically necessary, then, or if the department has found in its review that there is coverage under the policy, then the department would direct the insurance company to process that claim or pay the claim. So that's that's a very high level explanation, and there's additional detail on the department's website, and like I said, I'll give you a link to those at the end. Okay, so now that was healthcare appeals, if something is denied. So most other things will fall under the bucket of a provider grievance. And these are, I don't know how big this is on the screen. Oops. So forgive me if this is kind of small print. But basically a provider grievance by statute is a written complaint submitted by a healthcare provider and received by a health insurer. But there are certain things that are not grievances. One of them is a denied claim or a denied service, and that's C. If we were to receive something through the provider grievance process that related to a denied claim or denied service, you would get a polite letter from the department that said, I'm sorry, this is something that has to be submitted through the appeals process to the insurance company. And we wouldn't process it as a grievance. So that's one thing that is not a provider grievance. We also can't look into matters where a non-contracted provider is disputing the fact that they're not being allowed by an insurer to become a contracted provider. Now, a distinction I want to draw, though, is credentialing. So if there is a provider who is going through credentialing and believes that there is some issue with the credentialing, particularly related to the timeframes, there's statutory timeframes for credentialing. If a provider has a dispute about that, that can be submitted as a provider grievance. And also, we would not look into grievances related to an insurer being terminated from a network. So basically, the law requires that insurance companies have an effective provider grievance process in place. So we would encourage any providers who are having disputes with insurers to initiate a grievance with the insurer about it. If you don't get, if you feel the insurer is not providing you timely responses, or a response that satisfies your questions or concerns, at that point, you can submit a grievance to the department for us to look at, because now there's a question about whether or not the insurer has an effective provider grievance process. So this, I'm going to show you really quickly how to submit a grievance to the department. You go to, there's the website for submitting grievances. It is, oopsie, there we go. There's the right page. So we have a page under insurance, healthcare providers, and then you get here. And I'm going to make a comment here about the fact that not all types of health plans or health benefit plans are under the jurisdiction of the Department of Insurance and Financial Institutions. We do get a lot of grievances about Medicare plans, i.e. Medicare or Medicare Advantage plans, access plans, and self-funded plans. And those are not within our jurisdiction. So if you know that your the health plan that isn't paying the way you believe they should, is one of those types of plans, on our website here, we have links to the organizations that may have dispute resolution mechanisms for you for those kinds of plans. So if you aren't sure if the health plan that you have the dispute with is a fully insured commercial insurance policy, look at the member's ID card, because there's a relatively new law that requires that on the bottom of the member ID card, it has to say AZDOI, AZ Department of Insurance, on the front of the card. And that will tell you that it is a health plan that is within the department's jurisdiction. So I just wanted to point those things out really quickly. Then from this main page, you click on consumer complaint. In this instance, the provider would be a consumer, and this form will pop up. And yes, it says consumer, but you are the consumer. The most important things on this page are you the insured? No, you are not, but you are a healthcare provider. And I hope that my screen is showing, because I can't see what's on the screen. So hopefully it's showing a big Arizona on the screen, Lynette.
Yes, you can see it, the big Arizona.
I presume somebody would have told me if when I was changing screens it wasn't showing. So thank you. So that's an important starting point, is to make sure that you indicate that you're a healthcare provider, and then that complaint will be transmitted to an individual in the department who handles provider grievances. And we have one person who spends about a quarter of their time on healthcare provider grievances among other responsibilities. So it's unfortunately not a significant resource, but again, I mentioned that only as explanation for why it's super important that you use this electronic submission mechanism, because then all of the information that you provide is automatically uploaded into our complaint tracking system, and it saves an awful lot of time for this person. So then you'll come down and you'll need to put the insured's information. There's a place in here where you're going to want to put the insured's policy number, or what you probably have is their subscriber or member number. And you'll want to provide that. You may not, oh, here's the policy number. You may not have some of this information relating to the insured, and that's okay. You're going to want to put as many details about the problem or issue here in the details, and you can provide additional documents. To do that, this little note here, it says, after submission of this form, you're going to be given an opportunity to submit documents. Please click yes. And my understanding is what happens then is you will get an email from the department, from the system saying, oh, here's the link that you use to submit additional documents. Then you can provide copies of claim documents. You might provide a copy of the member's ID card. You might want to upload a spreadsheet with all of the claim, the patient's information. If you have multiple claims for one insurer that were denied, that you want to transmit in one grievance. So those you can definitely do that. And we would encourage you to please provide those additional details using that mechanism. And then you'll want to go ahead and receive an email confirmation that you submitted a grievance, and then submit your authorization and say you're not a robot, and off you go. So that is the process for submitting a grievance. This is just a recap of what I said about the department's jurisdiction for grievances, and a little reminder about looking for AZDOI on the member ID card. And just a reminder that over on the department's website for providers, we do provide this link to other resources. If the dispute is about one of these other types of health plans or health benefit products, there are some other resources for you there. So, and then the last slide I had was just if you want more information on appeals or provider grievances, there's the links to those resources on the department's website. And I'm happy to answer questions if anybody has any.
And if anyone wants these slides, are they available to be sent out?
Sure. Absolutely.
Any questions for Erin?
Yeah, if we want a copy of them, should we just contact Erin?
I can get them from her and send it out to the group.
Okay, thank you.
Yeah, I can do that. I'll PDF and send it to you, Lynette, and then you can just send it out to the members.
Good.
Thank you.
Any other questions for Erin? Okay. Any topics? Oh, Erin, go ahead.
I just thought of something, something I didn't mention. I haven't seen the statistics in a long time, so they may not be accurate anymore, but I know at one time, healthcare appeals, it really pays to appeal because at one time, at least 1 in 2 claims, 50% of appeals were overturned at the insurer level. That drops off a little bit when you get to the external review, because by then the insurance company has had an opportunity to review the denial and make a change if it's warranted. So I don't know if the numbers, I don't know that the department even has that information anymore. We used to collect it a long time ago, but I just wanted to entice folks, if you weren't aware of healthcare appeal rights, that it really can make a difference. And I don't know, I don't want to put anybody on the spot, but if any of our health plans want to say anything about appeals or grievances, they're welcome to, but don't want to, no pressure.
I will just
No,
add,
I agree. This is Rogers. I agree with the process you just reviewed. It's pretty much standard.
yeah, and this is Vista from Blue Cross. To your comment about the turnover at even at the insurance level, what so often happens with appeals is that we get much more information about even grievances about the claim that wasn't available before. And so that accounts for some of the turnover. And the other point you made early on in the presentation is just that the definition of member includes treating provider. And I think, when you read through that law, you see the word member. Unless you've looked back at that definition, it's not intuitive, and it's not like the sort of parallel federal law that exists where a lot of the rights belong to the claimant, and you have to have special sort of authorization to represent somebody sometimes. It's not like the treating provider can't do it under federal law, but it just takes more process. So, and for our self-funded groups where there is no DIFI jurisdiction, we have similar processes, but instead of you procuring the independent review organization, we're out there contracting with them to create that external independent review at that level.
So Vista, if you can, if it was a self-funded plan, would a provider who had a dispute about a self-funded claim, would they just contact the health plan directly, or is there another mechanism that they would need to go through?
We do receive complaints from providers. It may depend on exactly how the self-funded group health plan is organized. Their own summary plan description as to whether, for example, if a treating provider wanted to be the representative of the member or the claimant on behalf of that appeal, whether or not a special form was required, which is sometimes the case, or sometimes as part of the authorization, as part of just the whole entry process for, treating a patient, providers secure that kind of permission. And it becomes very case specific, but we do see those kinds of appeals as well.
Thank you.
Yeah, and we do see providers not giving the information needed for determination. So sometime in the peer review process, when we're talking to the providers, we're able to get that information and authorize in real time, just because that was missing from the initial submittal. So it's really about clarifying and getting the information to determine medical necessity. And sometimes the office doesn't send it in and the provider thinks it was sent in. So it's an opportunity for us to get the information so we can approve.
This is Carrie from Mercy Care. I'll just echo that same thing. We do find that a lot of the appeals are able to be overturned, and the primary reason is what others have articulated. It gives us the time to be able to get the right information to make the best decision on medical necessity. And sometimes it's that peer-to-peer. Sometimes it's just timing of the records weren't available, all of those things. But I agree. This was a great presentation, and we definitely agree with that if folks, that we encourage folks to appeal so that it kind of gives that ability for the health plan to take a look at, or to have the opportunity to gather more records and do a more thorough, hopefully, evaluation of additional material to help support the need. So this was great. Thank you.
Good. Thank you.
Any other questions for Erin? Okay. Are any future topics anyone wants to toss out there for the next meeting, which will be October 20th? Can't believe we're almost in fall, everyone.
I will just, I don't have a topic, but that will be my last Mental Health Parity Advisory Committee meeting. I am retiring from the department after 34 years. So I just wanted to let everybody know that, and I'll save my emotional mushy stuff for later.
Congratulations, Erin.
Oh, yeah, congratulations, Erin. That's
Oh, you can't
sad
go.
for all of us. We'll miss you.
Thank you. I will miss all of this too.
When is your last day?
November 6th.
Okay, wow. Amazing. Well, you've done so much for the state. And I know, having worked with you in the past at Access and everything else, really appreciate everything you've done for the state. Thank you.
Thank you.
Yeah, ditto. Absolutely.
Thank you all.
I'm still
Definitely be
there
noticed.
and just can't through. One thing that I'm not even sure how we would begin to explore this, but I've thought about it a lot as I've been looking at the new, proposed rules on parity. There are a lot of expectations built into those rules about network adequacy. And I'm just not sure what the picture is in the state of Arizona of providers. Because I think there's been, we don't have enough of them on the behavioral health side. And so I think providers do well sometimes without needing to contract with an insurance company. And I don't know if there's any way to get at the sort of the number. I mean, how many psychiatrists do we have in the state of Arizona? Because even if you were to go to, say one of the medical board, are they going to have everybody listed? Are some people listed but not active? Is there any way to gather information on really just the numbers of providers that we have here who are available for contracting with? Anyway.
I think would be a great project if we could figure out how to, and not just for psychiatrists, but across the board, LPC, social workers, the whole bit.
So
I can
suggest maybe you contact each of the various boards. You probably want to do the medical board, the nursing board, like they have psych NPs and things. Do you want to do the board of behavioral health examiners? Do you want to do the psychology board, which also does the ABAs? And maybe it just hit those and just say, here's what we're looking for. Some of them might be able to tell if they're retired or not, but see what information maybe just they might have and suggestions they might have.
I can speak for the Arizona Behavioral Health Examiners. They do keep a list. They have a large number, and then they have it narrowed down to those currently practicing. They do keep it by retired, so we can get a good view of that sector. I don't know how the other boards, track individuals. Also, too, I do know, speaking from social work, that the social work schools are training new graduates that if they want to be lucrative in the field from the therapy standpoint is to go private practice and not contract. So I do know that's happening. So it's a good discussion for.
Yeah, that's becoming a big issue in Arizona, physicians not contracting with payers. I do early mentorship with early career psychiatrists. And I think I have about 3 right now that I'm working with. None of them contract with any insurance companies. And I become really concerned that they are going to see a skewed patient population and not develop skills to treat people who are SMI because those patients may not be able to afford $200 or $300 an hour. So it is something we're facing within Arizona.
And if I might play a little bit of a devil's advocate too, from what I understand from a lot of providers, is that the payment rates of commercial and Medicaid are too low, and they can just go on their own and do cash private pay.
And I've heard all of those nuances as well. So I can definitely put it on the agenda, and maybe as a committee, we can figure out how to do something to disrupt this thing that's happening here in Arizona and get more providers into the system. So we can meet the needs of the patient. So thank you, Vesta, for bringing it up. I will add that to the agenda. Anybody else? Topics for next meeting? I'm sure we could talk about network adequacy for like hours and hours and hours.
It's really a challenge because I think the rules, they definitely have an expectation about adequate networks and the special efforts that will be required of plans to, if you want to assert that you just can't get providers into your network, that what efforts did you make to get them? You know, including increasing the amounts that you're offering as reimbursement. And so, will that, how high do we have to go? Because we obviously have a mission, you know, for in terms of our members and our groups to maintain affordable coverage. So I think it's, and I think all that will probably be explored during the comment process on the proposed rules. It's going to be interesting to see how the rules wind up after all the comment period.
Underneath that topic, I'll just add the subtopic about rates. I will also add reciprocity and compacts come into play as well. With that, with people with telehealth, and you can live in, you know, I can live in Jamaica and be doing services here, and what does that look like, and how does the licensing come into play with that, because that impacts adequacy as well. And how do these telehealth platforms like Better Talk and Talkspace and those, how do those impact adequacy? Because some of those only contract with certain insurers, and so I know that will limit some, it will help others, and so I think all those subtopics feed into that bigger topic of network adequacy, especially here in Arizona. Anything else? Erin, we can see your screen, your chat screen.
I didn't know I was still sharing. Oops. Thank you.
Again, our next meeting is October 20th, 2023 at 12 noon. Any other comments for the greater good before we leave? You get 15 minutes back of your Friday. Okay. Thank you, everybody. I appreciate it. Have a good weekend. Hopefully it'll cool off and we can enjoy some good Arizona weather this weekend and stay dry in the monsoon. Take care, everyone.
Thanks, everyone. Special thanks to Elian.
Yes, thank you, Elian.